increase, what happens, the TAG, that is a triacylglycerol, is broken down to fatty acids and the glycerol. And this fatty acid enters the circulation. Once it is utilized, and rest of the fatty acids are stored in the adipose tissue because of the help of the GAP hormone, which has got a tendency to imbibe more amount of, the adipose tissue has got a more tendency to imbibe the fatty acids as a storage. It's a storage site. Adipose tissue is a storage site for the excess fatty acid substances. So it stores, and whenever it is needed, it is released in the circulation. So it is got such a beautiful lipid buffering capacity with respect to the GAP hormone activity. Of course, even the reduced pro-inflammatory immune cell infiltration, when the cells enlarges, the adipose tissue enlarges to a greatest level, and no longer it can accommodate the fatty acid, what happens? Immediately the pro-inflammatory cytokines enter into the site, and it will destroy the adipose tissue, and it will cause a fibrosis and cell death. So this will be prevented by the GAP hormone. So these are all the extra benefits that the GAP hormone has got with respect to the adipose tissue level. And if you see the unique action of the GAP at the pancreatic level also, the contribution of insulin secretions is by all these three factors. One is the substrate absorption, which amounts to almost 33%, and with respect to the GLP-1, it has got 22%. See that hormone GAP, it has got almost 44%. So contribution of insulin secretion is more with the GAP than with the GLP hormones. Of course, you can see not only with the contribution of insulin secretion, but also the insulin mediated glucose clearance is also very good with the GAP hormone. So having said about all these things, the beneficial effects of the GAP with respect to the central nervous system action, pancreatic action, and then adipose tissue action, let us now go to the trials, what they have done. So these company people, they want to have a trial, head-to-head trial with the other GLP-1 molecule, semaglutide. What they have done, they have done two trials, head-to-head trials. One is how the molecule is superior in glycemic reduction, and how this molecule is superior to in the weight reduction. So these are the two parameters they had in their mind, and they focused on these two trials. So let us go to the case history. The Anjali, she is living with the obesity without type 2 diabetes, non-diabetic obese individual. Why should we consider Mounjaro for your patients? This patient has got a tried with the multiple times of the weight reduction programs, and successful at losing weight and maintaining a weight reduction over time. So what we are going to consider for this Anjali, whether you're going to put her on GLP-1 receptor agonist or this tirzepatide molecule, dual GAP and GLP. So what you are going to do for this patient, non-diabetic obese individual who has been unsuccessful in weight reduction programs and other by means. So this is done in the SURMOUNT-5 head-to-head trial, where this trial is a phase 3 multi-center randomized parallel arm open label active comparator control trial. So this trial has got two arms, one is a Mounjaro and the second is a semaglutide arm. And the people selected were the obese patient with a BMI of more than 30, non-diabetic patient BMI more than 30 or BMI more than 77 with some comorbid conditions of the obesity like hypertension or dyslipidemia or sleep apnea syndrome or even the cardiovascular disease. So these were the things the patient was selected. And the secondary endpoints they have, the exclusion criteria they have done is the patients with the weight reduction programs whether they have attained, whether the patient has attempted any weight loss programs or going for any surgical procedure interventions, all excluded from the criteria. So they have done this trial with a slow escalation of these drugs. So Mounjaro was given the total targeted dose was 15 milligram, but they didn't give it 15 milligram at a stage initially immediately. Why so? It means initially when this molecule was invented, that molecule was compared with the dulaglutide molecule. It was 1.5 mg of dulaglutide was compared with 15 mg of tirzepatide directly. And so patients went for severe vomiting and severe weight loss and lot of side effects. So what they thought, so okay, this molecule cannot be given at a loading dose of 15 mg, we can have to slowly up titrate the dose from 2.5. So that's why that all the trials have conducted with a slow escalation of doses from 2.5, 5, 7.5 and 10, so 12.5 and then 15, 10 or 15. So like that they went to each 2.5 milligram of increment every month. And the same thing happened with the semaglutide also. They are given 0.25, 0.5 and 1 and 1.7 and 2.4. So this is the way they updated the dose of the semaglutide and the tirzepatide. So this Mounjaro and semaglutide were administered subcutaneously as an adjuvant to the reduced calorie diet and increased physical activity. The primary endpoint, percentage of change in body weight. They want to assess the body weight mainly. So they have gone to the trial data. We will just see this. What happened at the end of the 72 weeks of the trial. So Mounjaro has, at the maximum tolerated dose, demonstrated superior reduction in the body weight compared to the semaglutide molecule. Almost you can see 21.6% of body weight reduction is seen with the Mounjaro, whereas in semaglutide arm it is 15.4% of the reduction at the end of the 72 weeks. So whether it is only the weight reduction that has occurred, it's not only that, but 1 in 3 participants taking Mounjaro achieves more than 25% of weight reduction. 1 in 3 patients, 25% of weight reduction. Whereas in semaglutide arm, 1 in 5% solely taken, they have reduced to almost more than 25%. So with respect of semaglutide, tirzepatide has got a edge over the molecule of almost 1 in 3 patients achieved more than 25% of the weight loss. Of course, not only the weight loss, even the waist circumference is also much reduced with the tirzepatide molecules, almost 20 centimeters. See that 7.9 inches. They wouldn't have gone. Almost all the dresses would have gone definitely waist. They would have changed to all the new dresses only. So waist circumference has gone almost 20 centimeters less. Waist circumference has gone down drastically. So the BMI has reduced. Even 1 in 3 patients achieved with the weight reduction of more than 25%, and the waist hip ratio also much reduced. So with these trials, they have concluded that tirzepatide molecule is not only inferior, but also it is superior to semaglutide molecule with respect to the weight reduction. Now the second trial, that's a SURPASS-2 trial. So far we have done about the weight loss. Now we will see how the glycemic control is superior with the tirzepatide molecule when compared to semaglutide molecule. So Janvi, she is concerned about her future with type 2 diabetes. She is concerned about unsatisfactory HbA1c control and future implications of her excess weight also. So she is concerned with both aspects, not inadequately controlled blood sugar level and also the weight gain also. So why should you consider Mounjaro for this patient instead of other GLP-1 receptor agonists? What are you going to choose for this patient? She is concerned about glycemic reduction and even weight loss also. This is done with the SURPASS-2 trial. They compared these two molecules, head-to-head trial. So the patients, type 2 diabetes patients with the A1C of more than 7 to 10.5 was chosen. The baseline BMI was more than 25, and the secondary endpoints of the exclusion criteria as well. The patient with any retinopathy was not selected. They were excluded from the thing. eGFR of less than 40 was excluded. So these are the exclusion criteria. With this trial, you can see overall mean baseline A1C was 8.3, and mean duration of diabetes is 8.6 years. Baseline BMI is 34 kg per square meter, and the patients enrolled almost 1,879. It was 1:1:1:1 ratio. They have formulated 5 mg, 10 mg, 15 mg of tirzepatide 3 arms, and the fourth arm is a semaglutide molecule. As I told you, the same type of dose escalation was done. 2.5 starting with every month, increasing to 2.5, attaining to 15 mg. Semaglutide also 0.25, 0.5, and then 1 milligram they are gone. So the primary endpoint was mean HbA1c reduction, change from the baseline, and secondary endpoint was a weight reduction also. And of course, how much of 10%, 15%, 20% weight reduction has occurred. All these things came as a secondary endpoints. So the results were, there was a superior mean HbA1c reduction across all the 3 doses of tirzepatide molecule versus the semaglutide molecule. You can see 5 mg has reduced to 2.1, and 10 mg 2.4, and 15 mg 2.5. Semaglutide has almost reduced only 1.9. So even the lowest maintenance dose of tirzepatide 5 molecule demonstrated superior mean HbA1c reduction versus the semaglutide molecule. Even the least dose of 5 mg have got a more reduction of HbA1c than the semaglutide arm. Of course, secretly more patients achieved with all the doses across the semaglutide molecule, and superior mean weight reduction also has occurred in all the 3 doses of molecule. So superior weight reduction that did not plateau over the study period of 40 weeks with the semaglutide. You can see the study period of the reduction that doesn't attain any plateau. It's going on reducing with the tirzepatide molecule. Of course, the more patients achieve the composite endpoints also, 5 mg, 2 mg, 10 mg, 15 mg, almost 32, 51, 60%, and semaglutide is 22%. So if you see the tirzepatide 15 mg, almost 3 times that of the semaglutide molecule it has achieved. The adverse reactions, you know, all these things are common: nausea, constipation, diarrhea, vomiting, fatigue. All these things are almost common with almost, they compared with the Mounjaro with the semaglutide molecule. Is almost same only, except the vomiting is slightly higher with the Mounjaro group, 10.4, and semaglutide is 12.1. But other adverse reactions are almost same with the SEMON 5 trial. The overview of AE reactions also almost the same with the TEAEs and the SAE, serious adverse reactions, and other things. The most AEs are the nausea, diarrhea, vomiting, dyspepsia, decreased appetite, constipation, abdominal pain, which is common with, we expect with all type of GLP-1 receptors. So summary: tirzepatide MT demonstrated superior weight reduction, tirzepatide demonstrated the superior HbA1c reduction. So weight reduction was more with the tirzepatide molecule when compared to semaglutide molecule. Of course, instead of hypoglycemia is very less with this molecule. The starting dose we had to go from 2.5, step up slowly as I told from the studies, and probably if the patients are already on metformin and SGLT2 can be continued, but when patients on sulfonylurea and the insulin, the dose has to be reduced, and no dose adjustments needed for the age, gender, and no dose adjustments required for the people with hepatic or renal impairment. Only thing, ESRDs and severe hepatic impairment, the drug should not be given. Acute pancreatitis, pregnancy, breastfeeding to be avoided, and even patients with retinopathy also who is request treatment should be avoided. And if you can see how you are going to manage eating small amount of foods for the patients you are going to tirzepatide prescription, you have to give this kind of advice.
Can you conclude, sir?
Thank you.
Very well about why we eat and our desires and things. Is it really possible to make our eating habit change without pharmacological intervention?
Absolutely. So two